December 12th edition of N3C Community Forum. We're almost wrapping up with the year. Next slide. So the feature talk will be from Jana, Ponce, about malnutrition and COVID, hospital-acquired malnutrition and COVID. Use your Q&A button or chat for questions. We work with both. Sessions are being recorded. Next slide, please. So the last presentation of the year is next week. Tips and tools exporting code from the enclave to GitHub, which is obviously very important as there's increasing uptake in generalizing N3C software and methods to a broader set of use cases. And so getting code to from the enclave to GitHub so it can be used in other environments is really essential. Then next year, January 9th, metformin is associated with less severe COVID-19 analyses, and a phase 3 trial inspired by that from Justin Reese and Carolyn Bramante. It'll be interesting to sort of get an idea as to what degree metformin is independent versus dependent variable in this. Then January 23rd, C4R project, collaborative cohorts for COVID-19 research by Elizabeth Ponce. Next slide, please. So we have an update. I'm pretty sure. So 563,000 COVID positive cases, 16.9 people total. Next slide, please. And so this talk, which really actually seems very intriguing from both the results and a methodological point of view, is analysis of malnutrition on outcomes and determine how pre-existing or hospital-acquired malnutrition impacts patients hospitalized with COVID-19. And Dr. Ponce is a registered dietitian, an assistant professor in Medical Nutrition Education Division of the College of Allied Health Professions and Nebraska Medical Center. So she's a real expert in malnutrition. So this should be actually very interesting and valuable talk. So Jana, if you can share your slides, I'm interested to hear what you have to say.
Yeah, thank you for the introduction. Let me get my screen shared. All right, is everyone seeing the slides?
Yep.
Wonderful. All right. So my name is Jana Ponce, and this is the impact of malnutrition on clinical outcomes in patients diagnosed with COVID-19. And I'll let my collaborator, Jared, introduce himself as well.
I am Jared, and I helped with study design for this project and clinical informatics support. So I am here to answer any of the informatics adjacent questions that may come up.
And we are both from University of Nebraska Medical Center and Nebraska Medicine. For those of you who aren't really too familiar with malnutrition, malnutrition is really a state resulting from lack of uptake or intake of nutrition that leads to altered body composition. And on the screen, you'll see a picture, and I really like this picture because it really starts to speak to the difference between chronic versus acute malnutrition. On the left side of the person's body, you can kind of see that chronic, really familiar state of malnutrition that most of us are used to, a really starved looking person. But there's also acute malnutrition, and that's represented on the right side of the picture. And acute malnutrition can be thought of as somebody who's just really all of a sudden stopped eating. And that really pulls from stores that we really need to fight chronic or acute diseases. It pulls from your muscle tissue, it pulls from vitamins, minerals, and really all those micronutrients that are really important. So we assumed that since malnutrition is associated with poor diaphragmatic and respiratory function, that we think that patients who are diagnosed with COVID-19 might have poorer outcomes. But on the other hand, those patients that didn't have underlying malnutrition had a high risk of becoming malnourished during hospitalization because of symptoms that are associated with COVID-19, such as anorexia, nausea, vomiting, and hypermetabolism. So there are several gaps in knowledge regarding the impact of malnutrition on clinical outcomes, including there's really limited data in the US assessing prevalence of malnutrition in these subjects, no US data assessing the impact of malnutrition on outcomes, and there's no data that really looks at the differential effects of pre-existing versus hospital-acquired malnutrition in patients hospitalized with COVID-19. With this in mind, our research team hypothesized that a history of malnutrition or becoming malnourished during hospital admission is associated with increased mortality and poor clinical outcomes in these patients. And this hypothesis led to the following research questions. 1, what is the prevalence of malnutrition in patients hospitalized with COVID-19? 2, how does malnutrition impact those clinical outcomes? And 3, what are the differential effects of those clinical outcomes in patients who have underlying or hospital-acquired malnutrition? I'll let Jared speak to the background here.
Yeah, so this study came about as a result of a previous study within N3C led by Dr. Bailey from the University of Nebraska Medical Center on alcohol use disorder. As part of that study, we looked at concomitant malnutrition in those with alcohol use disorder. So it was kind of the seed for this project. And because of the interaction between malnutrition and alcohol use disorder, Doctors Ponce and Bailey, or Doctors Ponce and Hansen from UNMC were brought in, and this research team was built. So we utilized N3C release 55, which was from December of 2021. It is shocking to me that since then we've had almost that same number of releases and more than twice as many COVID patients in N3C. We did use level 2 data, so that means we didn't have access to non-shifted dates or 5-digit zip codes to account for this. All of the outcomes you'll see in this project are inpatient outcomes, since we didn't have a good way to censor at the patient level with date shifts. And that allows us to have higher likelihood that we're not inadvertently censoring people that are just getting close to the current date. We developed a computable phenotype for malnutrition within Atlas, and then Doctors Ponce and Hansen reviewed it clinically, and we like to use a process where we validate any computable phenotype locally using our source data from Nebraska Medicine. So that gives us more access to, granular data. We can access the source, so we can look at things like EHR vendor groupers and department IDs to see if we're, getting all of the patients and making sure that we're not inadvertently getting false positives. And after that process, we incorporated it into the N3C knowledge store. One thing that was a pleasure to see as a result of this project that we don't often get to see from an informatics perspective, that Dr. Ponce will talk about later, is the direct impact that this work has on results dissemination and potentially clinical care. And I think that is, one of the highlights of what you'll hear her talking about over the next few minutes.
Thanks, Jared. To continue with the overview of the project, the duration of this project was very short. As you can see on the left hand of this timeline is 2021, and over on the right side is 2022. We began our malnutrition and N3C data analysis plan in July of 2021. Everything in green kind of relates more toward the investigation portion of the project, while everything in the blue represents more of the clinical translation portion of the project. So from analysis to journal submission, we completed this within 6 months. And from analysis to translation to clinical practice at an academic medical center took about 9 months. Next, we'll move on to our methods. I broke down our methods, the procedure portion of our methods, into 5 different steps. First was our data use agreement completed with N3C. As of note, Nebraska Medicine is an N3C contributing partner. Second, we defined our data analysis plan. Third, we developed our clinical concept sets. Fourth, we stratified our cohort by malnutrition classification. And finally, we did that final data extraction on December 2nd, 2021, and completed our statistical analysis. The primary exposure in this study was malnutrition, and outcomes for the primary outcome was death or transfer to hospice, with secondary outcomes including adverse hospital events, including mechanical ventilation, acute respiratory distress syndrome, or ARDS, extracorporeal membrane oxygenation, or ECMO, and hospital-acquired pressure injury, or HAPI. In this figure, you'll see our data analysis plan. In that first box, in the light blue box on top, you'll see that we started by including all patients with a definitive diagnosis of COVID-19, and then moving from top to kind of bottom. I moved this so you could see it a little bit bigger. You can see our exclusion criteria. So first, we excluded any patients from sites with incomplete hospitalization or death reporting. Next, we excluded patients with missing age, gender, or those pediatric patients under the age of 19. And finally, we excluded patients with a COVID-19 associated diagnosis, without a COVID-19 associated diagnosis within, or hospitalization within 14 days of diagnosis, excuse me. And that left us with our final hospitalized cohort of 343,188 patients hospitalized with COVID-19. Jared alluded to this briefly in his previous slide, but third was our development of concept sets. Although criteria do exist for the identification and diagnosis of malnutrition, it is not uniformly diagnosed due both to subjectivity and non-uniform training. Therefore, we utilized ICD-10 diagnostic codes to develop our unique concept set. Our team collaboratively reviewed 166 unique codes relating to nutrition that in 16 that our team felt encompassed diagnosis consistent with malnutrition were included in our concept set. So as you can see in this brief screenshot here, you can see a lot of these codes relate to malnutrition or to nutrition itself, but may not distinctly represent malnutrition. So up on the top of the screen, you see deficiency of multiple nutrient elements. We may have considered that for our concept set, but we didn't feel as a group that that really would be something that someone would identify as malnutrition. Same with dietary zinc deficiency. However, in this screenshot, you can see that we did select moderate protein energy malnutrition, moderate protein calorie malnutrition, and mild protein calorie malnutrition, which seems confusing, but are all separate ICD-10 diagnostic codes that we believe may represent malnutrition in a patient with COVID-19. So moving on to malnutrition classification, on the left side of your screen here, you'll see those 16 ICD-10 diagnostic codes that we selected as representative of malnutrition. From there, we further subclassified our cohort by malnutrition status. So if a patient had a diagnosis using an ICD-10 diagnostic code of malnutrition based on those left-hand identifiers prior to hospitalization, we considered them to have a history of malnutrition. And those patients who received one of these ICD-10 diagnostic codes following hospitalization was considered to have hospital-acquired malnutrition. Moving into our statistical analysis, of course, first frequencies and percentages of demographic and clinical characteristics were calculated. And we also excuse me, groups were then compared using either the Wilcoxon rank sum test for continuous measures or chi-square test for categorical variables. And finally, univariate and multivariate logistic regression models were used to evaluate odds ratios of mortality and adverse hospital events based on malnutrition group. Adjusted models were controlled for age, sex, race and ethnicity, Charleston Comorbidity Index, and smoking status. And next we'll move on to our results. So here is a map that shows our geographic distribution of the cohort. And you can see here that we have a cohort that's representative, hopefully, of the majority of the United States. This is one of the largest cohorts done in the United States that has investigated malnutrition status. So up here you can see that in our final hospitalized cohort, that 343,000 patients, we subclassified those patients by malnutrition status. So 92%, or 316,000 of the patients of the cohort had no documented history of malnutrition. 3.3%, or over 11,000 patients, had a history of malnutrition, and 4.6%, or over 15,000 patients, had hospital-acquired malnutrition. For those of you really interested in our statistical analysis, here's a forest plot of our univariate outcomes. On the left side of this forest plot, you'll see our outcomes of interest, starting with our primary outcome with our secondary outcomes falling below that. Under the malnutrition status column, you'll see our no documented history of malnutrition, and hospital-acquired malnutrition. The crude odds ratios will be the column after that, followed by point estimates and p-values. As you can see, all of the p-values here are statistically significant, meaning all of our outcomes were also significant. Moving on to the multivariate analysis, after adjusting for age, sex, race and ethnicity, and CCI, as well as smoking status, each one of these results remains statistically significant. So we saw that odds of death or transfer to hospice were 1.7 times higher in patients with a history of malnutrition and 2.5 times higher in those with hospital-acquired malnutrition. In the same respect, odds of invasive mechanical ventilation were about 1.8 times higher in those with a history of malnutrition and almost 6 times higher with hospital-acquired malnutrition. Having a history of malnutrition increased odds of acute respiratory distress syndrome by about 1.1 times, and hospital-acquired malnutrition increased the odds by 2.5 times. Odds of ECMO were approximately 5 times higher in patients with a history of malnutrition and 13 times higher in those with hospital-acquired malnutrition. And finally, odds of hospital-acquired pressure injury were about 3.6 times higher in those with a history of malnutrition and about 7 times higher in those with hospital-acquired malnutrition. So what does all that mean? For me, what I would like you to take away from this was that patients with malnutrition who were hospitalized with COVID-19 were about 2.5 times more likely to die. They were 5.7 times more likely to require mechanical ventilation. They were 13 times more likely to require ECMO support and about 6.9 times more likely to develop a hospital-acquired pressure injury. Those results are sobering and very significant. Next, we'll move on to some translation and discussion. When asked about this study, generally people always ask what was the hardest thing? And I would say the diagnosis and classification of malnutrition status was definitely the most difficult. The gold standard utilizes the Academy of Nutrition and Dietetics and American Academy of Parenteral and Enteral Nutrition, or ASPEN, guidelines for the identification and diagnosis of malnutrition. To use those, you can see the table on the right is what is used to make those diagnoses. Not everyone is trained the same, and there's a subjective nature to this assessment. Furthermore, you did see that even in that small screenshot of the clinical concept set, that the diagnosis seem to be worded very similarly, and to differentiate those codes takes an expert in itself. So we can consider that even within the same hospital group, the same clinic, or, you know, from one side of the country to another, that providers probably aren't diagnosing malnutrition similarly. Someone might think that someone with severe protein calorie malnutrition should be diagnosed as such, while another might say that that person has cachexia and diagnose it that way. If that was the same patient, both providers may mean the exact same thing, but we aren't able to say, yes, that's exactly what they mean, and we're only able to take the codes that A&D and Aspen recommend. So we believe that the clinical concept set that we developed was the best way that we could possibly catch all of those diagnoses and hopefully catch the majority of the patients who had malnutrition either before contracting COVID-19 or receiving or getting malnutrition following admission. We also think that a really difficult part of this study was introducing a strategy to differentiate acute versus chronic malnutrition. So if you can think back to that first slide, I'm talking about the person on the left side of that picture versus the person on the right side of the picture. The person who has completely wasted muscle and fat stores versus the person on the right hand of the screen that probably just more has wasted protein stores and wasted muscle, but their adipose tissue is still present. Currently, both of those patients are kind of treated with a blanket treatment. We try to improve their malnutrition as fast as possible, but there's not really a way to say, can we treat this one in a way that would be most beneficial to this patient and treat the other one in a way that would be most beneficial to them. We believe this study really highlights the need for early and frequent nutrition assessments in this population, and that this information needs to be translated into acute care as fast as possible. Like I just mentioned, we think that introducing a treatment to acute and chronic malnutrition as separate conditions that can have targeted interventions is a really important step that we need to take in our field, and something that I think this study, although it wasn't the initial aim of the study, is something that we were able to introduce, and it has a lot of impact that I think will have further downstream implications. Jared will speak to this in a little bit, but we do have some future studies with some investigation into the impact of micronutrient deficiencies on clinical outcomes. And we also plan to explore the impact of malnutrition and micronutrient deficiencies in the development of long COVID and its symptoms. To speak on some dissemination of this work so far, it has been presented both nationally and internationally. It's been presented at the American Society of Parenteral and Enteral Nutrition as a platform presentation in Seattle, Washington last year, COVID in the MENA region as a platform presentation in Turkey, as well as the American Thoracic Society as a poster in San Francisco. This manuscript was published in the American Journal of Parenteral and Enteral Nutrition, and that was, I think, in last month's paper copy, and it's also available online. There was a podcast interview on the manuscript itself that is published in November. And one of the most important things, I think, is that the impact of this work has led to practice change at Nebraska Medicine, which I'll discuss in the next couple of slides. Along with being an assistant professor at the University of Nebraska Medical Center, I'm also an inpatient clinical nutrition supervisor at Nebraska Medicine. So following the sobering results of this work, we as a department recognize the need to incorporate these findings into clinical practice as fast as possible. So we mobilized a group of registered dietitian nutritionists who can be referred to as RDs, RDNs, nutrition therapists. We respond to all of those. And we mobilized them to serve as content matter experts on a COVID malnutrition committee. And I would just like to point out that here's our group of just some of our medical nutrition therapists at Nebraska Medicine. Our COVID malnutrition committee had the following priorities. First, we wanted to identify patients with malnutrition or who are at risk for malnutrition. And we did that by increasing screening and communicating risk to important stakeholders. We aim to have faster implementation of nutrition interventions, and that included patients who were at malnutrition risk and for patients who had poor PO intake during hospitalization. And finally, we wanted uniform decision-making pathways, and we wanted those in the form of decision trees, not only to help our staff know what to do and when, but also to be transparent to providers so that they would know what to expect when they had a patient with malnutrition or malnutrition risk come into their unit. So what we did was develop some nutrition decision trees. Here's an example of our ICU nutrition decision tree. And for those of you who are experienced with nutrition research, you will think this may look really similar to some decision trees that you've seen. However, what we did was really expedite the nutrition intervention portion of these. We used the critical care guidelines from Aspen and incorporated what we know from this research in order to expedite those interventions. And these have been taken to critical care decision-making committees and vetted by our providers and nursing leadership. And I'll let Jared talk more about our follow-up efforts.
Yes, great. Thank you. Yeah, so just briefly, we are doing follow-up efforts based on some of the work that's come out of the recover and long COVID efforts in N3C. We noticed that, micronutrient deficiency popped up there in some of the clustered models that have been presented. And so we are starting to dig into that. This shows, some of our preliminary findings. This is a post-propensity matched cohort of adults with acute COVID, adjusted for background differences and acute COVID severity, and micronutrient deficiency is, highly associated with an increased odds of being diagnosed or presenting with long COVID. So we're digging into that and doing some deep phenotyping of differences among those with and without micronutrient deficiency in their long COVID presentation. And then also this work has been used for the malnutrition project that Dr. Ponce just described in an N3C pilot short course that we ran over the summer. The link to the GitHub repository for some of those resources is there. But as Joel had talked about at the top of this discussion, we think it's very important to have reproducible workflows, and we are working to get an end-to-end template of this entire study released into the knowledge store by the end of the year. So you would be able to go there and bring it into a level 2 project to kind of see end-to-end all of the code used to actually generate these results. And when we ran this, 6 months later this summer, the interesting thing was that a lot of the findings in this actually got worse since we ran it in December, from December to June. So some of them actually, the odds widened a little bit, unfortunately.
All right, so just want to say thanks to our researchers on our research team, obviously Jared, Christina Bailey, Harlan Sales, our statistician, Megan Timmerman, Mariah Jackson, dietitians, Dr. McClay, emergency medicine physician, and Dr. Hansen, who's also a dietitian. Jared, do you want to do acknowledgements?
Yeah, these are just our funding acknowledgements. We'd like to thank the NIGMS support that's allowed the IDEA CTR programs to participate, and then all of the help from CD2H and NCAS to, really make this tool available, and all of you for being a part of the N3C community.
Right. Well, thank you. This is fantastic. Questions? I'm looking at the, okay. Great work, and as you say, sobering for hospital-acquired malnutrition. How did you distinguish malnutrition causing bad outcomes versus bad outcomes causing malnutrition? Great question.
That is a great question. So I don't know, as you can say, this work is observational. We can't assume causality in any of it. We've adjusted appropriately as much as we could with the very large cohort that we have. We can assume that, patients that do have more severe disease do have a harder time getting volitional intake, whether that is by feeding tube, by parenteral nutrition, or by oral intake. So, I don't think that we can say one specifically causes another, but we do see that this very significant relationship exists, and we're seeing it over and over again. And I think the only way we can do this is really to start looking prospectively at some of these outcomes and really seeing what we find. Of course, we really can't do any, randomized double-blind controlled trials and make somebody super malnourished, but I think when we see these types of results over and over again, we can say that malnutrition really is playing a role.
So this is really very interesting. When you deployed this at Nebraska, I assume you looked at diseases other than COVID. Is that right?
Jared wants to answer this too, so I'll defer to him also.
I think you're specifically talking about how you deployed the nutrition therapy component in clinic. Is that what
Well,
you're
let me be more specific. So you have a concept set or a concept sets that that capture malnutrition using a variety of lab values and observations of different sorts, which seems extremely valuable and quite generalizable. And my conjecture would be that, and maybe you've done this, maybe you haven't, but I'm actually real intrigued about doing it at Stony Brook, is basically looking at the efficacy of that concept set in predicting mortality and adverse outcomes in a variety of clinical situations. Because just the little sampler you showed, these things looked very plausible, but really, frankly, non-nutritionists wouldn't have thought of looking there. So this seems like a really interesting concept set. So maybe if you guys could talk about, what you're thinking or anything you've done or are thinking of doing in terms of leveraging this in a broader context.
Yeah, so for the computable phenotype validation that I discussed, when we develop computable phenotypes for use in N3C, we like to look at our local data just as kind of a second check because we have more access to the source material. So if you are developing a computable phenotype for HIV as an example, it's nice to be able to go to an HIV department and say, these are all confirmed HIV patients who are we missing, things like that, so that you can identify, both false positives and false negatives if you have access to that source material. So that was what I was talking about, but you could absolutely apply this beyond COVID. We haven't done that yet, but you're seeing some of the potential for it for sure. Interesting.
So Francisco side, no, thank you. Francisco side. Oh, by the way, so in the concept sets, is this something that that you're obviously, I assume you're making that available, that's something that can be accessed since you've gone through the process of making this reproducible. So Francisco Sai, with the nutritional interventions provided, did the patients recover faster and the length of their stay in the hospital become shorter?
Yeah, so this is an interesting question, and I've gotten it a lot, and I say this it's in a good perspective and bad perspective that unfortunately once we had the results, that's when we really saw the downslot of COVID. So those patients that were initially very, very sick with COVID-19, we kind of saw those numbers dip, gratefully, we were really happy about that, but on the same side, we didn't really see the impact of our interventions as much as we had hoped for. We are still in the process of looking internally at those patients, and we will hopefully be able to see what some of those outcomes are in the future. I think one thing that is different now is that a lot of patients that are hospitalized with COVID-19 aren't necessarily hospitalized because of the COVID-19. Some of them are, but definitely not the numbers that we used to see. So I don't think that we have a definitive answer for you yet, but stay tuned.
Great. Okay, question from Adam Wells. A couple of thoughts, questions. One, do you feel that those not recognized with malnutrition prior to hospitalization were actually overrepresented under due to challenging diagnosis process? Guess maybe we should do one of these things.
Yeah, that's a great question, and I absolutely agree, and something that we don't necessarily have a good way of fixing at this point. There's tons of patients that have malnutrition prior to hospital admission that maybe wasn't caught, wasn't diagnosed. We know that malnutrition isn't diagnosed as much on the outpatient setting. We know that, you know, there's not a monetary benefit to diagnosing malnutrition in an outpatient setting, which makes it less appealing to providers. We do know that that's a limitation of our study, is that there is a risk of misclassification bias, but we do think that the numbers in the study, we hope, are kind of helping to assuage that misclassification bias. We also know that sometimes if a patient did at any point have one of those diagnoses, that it could have been resolved when they were inpatient, but I'm sure Jared would say that we are looking within 2 years of these patients, like a 2-year history, so about January 2018. So we wouldn't necessarily assume that everybody who had malnutrition prior to admission would have had resolved malnutrition.
Okay, and would it seem that this may also be extrapolated to those at risk in the pre-hospital setting, and perhaps outpatient therapy may be a benefit?
Yeah, the at-risk population was probably you know, the first to go downhill once admitted, and we can't, unfortunately, especially with ICD-10 diagnostic codes, put in an at-risk group in here. We know that those ICD-10 diagnostic codes are for coding and billing, and not necessarily saying the extent to which someone is malnourished, which is you know, also a limitation of our study. But we believe that the concept sets that we did create were the best way we could start to introduce this topic. So those at risk, if there are any providers on the call, I would encourage those providers to be looking for patients with malnutrition risk prior to hospitalization, and sending those patients to dietitians before seeing these bad outcomes.
Okay, great. And then 3 is, I feel you've identified an arguable emergency need that needs to be met for the population. So Laura Chen asks, is data about parenteral and enteral nutrition usage available in the enclave? Is it possible to identify therapeutic interventions that may be implemented following a malnutrition diagnosis and subsequent outcomes beyond your Nebraska site?
Looks like Jared has an answer for Adam, and then I'll also defer to him for Lauren's question.
I'm just flagging them so they get removed, but yeah, I can try this. It would not be readily available unless a site has gone through the effort of mapping that flow sheet data from the EHR into some sort of a scale. To my knowledge, not a lot of sites probably do that. The social determinants domain team has done a lot of work with that for SDOH measures, but I think that malnutrition and nutrition therapy probably gets left to the side still.
What do either of you know, it's my own question, about what work might have been done in terms of assessment of malnutrition using imaging? So in other words, lots of patients get imaged. I would have to imagine that many types of imaging would actually give you pretty good data as to chronic malnutrition. I don't really know other people have looked at it. I'd imagine they probably have. Are familiar with that? That would seem like a very easy way of getting an assessment in a patient where you don't have a lot of other data.
Yeah, I love that question. Yes, you can use imaging as well as ultrasound to look for lean muscle tissue in patients. However, the knowledge by the dietitians, we're kind of just starting to get into that field, I would say. And to use the imaging, the software that would identify for you the extent of the malnutrition is either one, very expensive, or two, very, very hard to use. So I think we are in the kind of baby steps of that research, I would say. I think that it's a very interesting research question and something that we are actively pursuing here at UNMC, but the current guidelines don't utilize any imaging to diagnose malnutrition, so that wouldn't be something that we would use for our criteria currently, but something in the future that could be really interesting to look at.
Yeah. Cool. Well, really very cool. Any other questions? Let's see, we should look at the chat, look at Q&A.
I have
Oh.
one
ahead.
question, if that's all right. First of all, I just want to congratulate you both. I think this is some of the most profound results that we have seen out of the N3C, and also in just such a short amount of time. It's truly a testament to both of you as well as to the whole community. So thank you very much and congratulations. The second thing I just kept thinking about the whole time you were presenting was, how do we get this in the hands of everyone? Like, because the reality is that the results are so profound that the ability to really influence care and outcomes trajectories is really very large. So and I know obviously you spent quite a bit of time talking about, just what you've done with your dietitian community, but how can we help you and help each other to take these types of results and really deploy them in an implementation science focused way? So I'm just wondering, this is really just a brainstorming question, if you have any thoughts about if you had your way in the world, what could we do next to really make that happen?
Yeah, I think more research obviously is always needed. We do need more research, but I think more national committees outside of just the nutrition groups really sounding off on how much malnutrition impacts clinical outcomes is really important. I think the utilization of this enclave made it so easy to show how impactful intervening with malnutrition can be. And I think another thing that's really, really important is just showing that those patients with hospital-acquired malnutrition did so much worse. I think that sometimes we think of chronic malnutrition, those are the patients we think of with malnutrition first, those that are severely wasted. But you can see with those results that the patients that, may have not gotten fed for 5 days or 10 days, or honestly, 2 weeks isn't out of the question for some of these patients that are on high dose pressors, on ECMO, that are ventilated. It's really hard to feed them, but it's not impossible. There are ways to do that. It's just kind of like, we always hear that there's one more day. We're looking for more advocates that can say, no, today's the day. We don't need to wait one more day. Their nutrition is really impacting how they're going to fare following this acute illness. So the more advocates we can have for that, the better, I think. And I was just going to share one more slide, if that's okay. This is not part of the presentation, and hopefully I'm not doing anything illegal here. I'm going to say this never happened if it is illegal, but here's our malnutrition capture rate at Nebraska Medicine, which I am pretty proud of. We do a good job. We really started to do some intervention work here with our nutrition therapists. The only time you can really see a downturn in our malnutrition interventions is here, right at the height of the 2020 pandemic. Really, you can see here that this is the time when we sent our nutrition therapists home. We said, don't go see them in person. We don't have enough PPE, et cetera. Those numbers went down. And I think this just speaks to how much we need nutrition therapists in the hospital identifying those patients with malnutrition or being at risk for malnutrition to push for those nutrition interventions to be started earlier. I think this showed, I think I can go to the next slide. We have a smaller community hospital, and we saw the exact same thing happen here, right? At 2020, those malnutrition diagnosis rates went down. So I think the other thing is just being an advocate for dietitians, or really providing more education to future and current providers regarding malnutrition and the need for expedited nutrition interventions in the acute care setting.
And
Right.
I would say that from I guess, what N3C could specifically do, you have these fantastic public dashboards for public health questions and things like that, and potentially allowing us to expose some of these research studies for those investigators who are interested might be a nice way for us to point our community partners and clinical collaborators to those as a real-time identifier of the impact of malnutrition, or insert project if possible. Yeah.
Right. So David Sarner, this may sound Orwellian, and I realize there would be huge practical, ethical, and privacy protecting issues to consider, but any thoughts about possibly leveraging PPRL, a patient preserving privacy linkage, consumer, e.g. grocery purchasing data to assess, for example, the extent of consumption of highly processed foods, et cetera.
I mean, I think that all of us or another, consented registry would have better luck with that patient level data, but you can use a proxy with food deserts based on where a residential address is in N3C. Not a lot of great options for that with 5-digit zip codes, but the social determinants of health domain team has done some work on that could potentially be leveraged to look at malnutrition in N3C.
Fantastic. Okay, no, thanks. And then Melissa, I guess you can speak for yourself. No, I agree. I'd love to be involved in that as well. We'd love to work on a public health dashboard with you on this. And I really do think actually analyzing routinely acquired imaging could be an incredibly inexpensive way of actually getting malnutrition information. I'm very intrigued, and you guys actually have ground truth. So without that, it's just a conjecture. The idea isn't you don't have to do special imaging. I mean, it could be chest x-rays, it could be CTs, it could be whatever is acquired. And my guess is that a good machine learning algorithm, good deep learning algorithm with your kind of carefully curated phenotype data would be able to give actually a malnutrition score just essentially based on images acquired for other reasons. So I don't know if it's true or not, but I'd love to find out.
I think one thing, absolutely, let's follow up and see about the dashboard. And I think that's one way of sort of getting it out there more. But I think another thing that, we've been, really working on, and this is work that was led by Emily Pfaff, where, we were able to recapitulate the N3C machine learning phenotype for long COVID in the All of Us platform. If we could come up with a sort of package that individual sites could run against their cohorts in a really well-documented way, maybe we could use this as an example of reaching out through the CTSAs and CTRs to really sort of help identify their own local patients using the same algorithm, recognizing that they don't have all of their patients currently in N3C, right? So at least those sites who are already participating kind of understand the value, but they could run it locally and potentially work on some implementation science and maybe coordinate across CTSAs and CTR institutions in that way. And I don't know if you guys have thought about that, but that seems like an obvious next step to me.
So Melissa, are you talking doing this beyond COVID for multiple conditions?
Yeah, beyond COVID, but also recognizing that, even patients that are basically even for patients that may have COVID, they come in, they don't all make it into the N3C necessarily, right? Because if they didn't have specific tests or diagnoses at the same time, like long COVID patients, for example, that may not have some of those features that would mean they were in the inclusion criteria. So I think it's important for basically everyone to have access to those kinds of methods to potentially identify for all conditions, but also in addition for long COVID patients that may not be.
But no, that's very interesting. And the relationship between this and Charleston comorbidity would be, I mean, you alluded to that, but this really could be as or more predictive, and basically utilizing data that might be in many ways a lot easier to obtain, because you don't have to I mean, it'd be interesting to see. I mean, part of the question is how correlated are they, which I'm sure they're pretty correlated. And then the other is in terms of data availability. I suspect that these are very complementary, that there are a lot of patients where you can't compute a reliable Charlson comorbidity. But I don't know. It's yeah, we really lack nutritionists.
Yeah,
So
I think it's interesting you bring that up, because I think the presentation that I was kind of alluding to that we're talking about is really our organization's efforts to step up malnutrition, because of the impact it has on expected length of stay, expected mortality, complexity levels of the patients. Those multipliers for both malnutrition and cachexia really increase significantly, which of course means more dollars for the hospital, which is always something that healthcare providers are looking for. But it really just speaks to how much even insurance companies are taking into account how bad malnutrition is. However, we don't necessarily take those steps within the hospital to make that not happen.
right. No, I mean, I've seen that. I mean, basically it's other things seem more important, and it's like, okay, the patient isn't eating and they're not being given really any nutrition, and I think it's just like one more day and we're busy doing the other thing. And
That's what should our new tagline will be, is like, oh, maybe tomorrow. Maybe tomorrow.
yeah. Okay, and Harold Lehman says a network odyssey study. Yeah, fantastic. All right, this was really fantastic, and really appreciate your talking. I think this hopefully will lead to some very impactful things. Let's see, am I missing anything? Let's see, chat, I think Q&A, I think that's it. So I think that's it. Any last thoughts or questions?
I just appreciate the N3C and your time. Thank you.
Well, really appreciate your efforts and both your results and your thoughts, and look forward to things coming out of this, or more things coming out of it. Okay, thanks. Take care.